Yeah, I'm on my phone.
And you can get on your computer at the same time. Yeah,
Oh, I
I
can.
You can't?
I can, but I just use my phone most of the time.
Oh, okay, it's live now. And then I'm just gonna continue folding my clothes.
Well, I'll let you go. I just wanted to see you a minute.
You can stay. You can stay on here if you want.
It's all right. I'll let you get back to work.
Have a good night.
Take care.
Have a good
You
night.
too. Bye.
Use that virtual. To bring out the best in me.
Really?
Ito na mo, Jack? Oh. Oh, nyata ako ba, Jack?
Orang tahu kaon batong.
Ha?
Itong batong.
Ah.
Baik, ikaw na lang mo kuhan.
Mama, nakatan?
Tigas banday.
Ang plansya ko na. Ang plansya ko. Nahugas ka? Magpabukot sa bata.
Pwede ka.
Oo. T-shirt lang mga ilisan? Nag-live ba ko?
Ha?
Nag-live ba ko sa YouTube? Bagay, maray ko. Lay, plancha na plancha mo. Bagra?
Isa.
Oh, isa yan. Dili, dali. Dali. Oh, nagbigyan na laptop. Ang ganun. Ito alam.
Ay, saswati dyan rin. Uy. Ay, saswati ba?
Amo, laptop. Amo,
Kailan mo kanila tulong ba? Ano kung yung nga natin na
Ton! Yan na.
We are Encompass Health, trusted experts in inpatient rehabilitation. We'll help you take the next step in your recovery. This video is one in a series explaining what to expect as we work together to restore your independence and self-care. Each video covers a topic we know is important to you and your loved ones. We encourage you to watch this video series at your convenience. Thank you for choosing Encompass Health. Here's a glimpse of what your stay may be like. You can expect at least 15 hours of therapy each week. You may be scheduled for therapy on weekdays or weekends. Your therapy will be based on your personal needs and progress and may include group or one-on-one sessions. We encourage you to begin each day by reviewing your therapy schedule. Your care team will help you prepare for each day's activities, including personal hygiene, getting dressed, and going to therapy. We'll review your progress often so that you can take on more care for yourself. In the beginning of your stay, please ask for our help in getting out of bed, using the bathroom, sitting in a chair, or walking. As you progress, your care team will let you know if you're free to move around on your own. You will have a nurse specializing in rehabilitation caring for you 24 hours a day. This care includes a full assessment of your skin, vital signs, breathing, and body systems. Please let the nurse know if you're not feeling well. Your nurse will bring your medications throughout the day as prescribed. Understanding your medication is important for your recovery. If you have any questions about the medications you're taking, please ask your nurse or the pharmacist to explain your medication and the dosage. If you're in pain, please tell your nurse. It may take 20 to 45 minutes for medication to work, so don't wait too long to ask for help. We serve breakfast, lunch, and dinner each day. Drinks and snacks are always available. Based on your personal rehabilitation plan and the meal options at your hospital, you may take your meals in the cafeteria, dining room, or in your room. Your dietitian can answer questions about your meal options and any diet restrictions. Your rehabilitation physician will visit you 3 times each week, and your care team meets each week to evaluate your progress and adjust your treatment as needed. Understanding your rehabilitation plan and how you're doing is absolutely necessary for your recovery. The My Encompass Health Caregiver app lets your designated caregiver stay up to date with your progress toward your goals, your anticipated discharge date, discharge instructions, and more. Rehabilitation may seem overwhelming at first. If you or your loved ones have questions about your care or progress at any time, feel free to ask your doctor or nurse or case manager. Therapy sessions are typically scheduled for morning and afternoon, leaving you to enjoy your evenings with a good book, your favorite television program, or phone calls with your friends and family. While our hospitals do not have a curfew, we encourage you to get plenty of rest each night. Thank you for choosing Encompass Health. It's our honor and pleasure to join in your recovery.
Hi, my name is Jenna Reagan, and I'm the lead outpatient physical therapist at Henry County Medical Center Center for Wellness and Rehabilitation. We are your last stop in your continuum of care. Our staff consists of 6 physical therapists and 2 physical therapy assistants, making us the largest outpatient physical therapy clinic in our area. Having a large staff offers us the opportunity to offer you multiple times that you can come into your therapy to meet your needs. As for your therapy, you will be attending sessions for 6 to 8 weeks. You will come to therapy 3 times per week, each session lasting approximately 1 hour. On your first visit, you will have an evaluation, and it will be performed by a physical therapist. During the evaluation, we will discuss with you your goals, your range of motion, strength, balance will all be assessed. We will discuss things with you such as pain management as well as swelling management. At the end of your session, we will be giving you a home exercise program. The home exercise program should be completed on the days that you are not attending physical therapy. It is essential that you complete this home exercise program on the days that you aren't here to receive the optimal results. For your therapy sessions, you're free to wear whatever you want to wear. Comfort is key. You can wear shorts, t-shirt, or whatever it is that makes you comfortable whenever you're exercising. As for your follow-up sessions, they will last for about an hour. Each session you'll come in, we'll start with a warm-up, we'll lead into balance exercises, strength exercises, stretching, which will be done either manually or you will do on your own. The sessions will usually end with some type of pain management. We offer cold packs, moist heat, and we also offer electrical stimulation if you are a candidate to assist with your pain. Our goal here at Henry County Medical Center, Center for Wellness and Rehabilitation, is for you to leave here being as independent as possible, no longer relying on an assistive device to ambulate and to be able to get back to your prior level of function. Again, we want to thank you for choosing Henry County Medical Center to service all of your needs. If you have any more questions concerning outpatient physical therapy, I hope that you will call me. Again, my name is Jenna Reagan with the Center for Wellness and Rehabilitation. Our phone number is 731-642-2411. Thank you.
Hi everyone. Today, let's talk about what you should do in an outpatient physical therapy clinic. So, by now, you probably have mastered how to introduce yourself. Essentially, for me, I go, hi, my name's Iman. I'm a student physical therapist. Today, I'll be working with you for the next 15 minutes. Is that okay with you? Throughout the process of working with you, I'm going to be needing to facilitate by putting my hands on your body and facilitate some movements that way. Is that going to be okay with you? You have your little spiel that you probably learned through your school, and if you haven't yet, this is something that you're going to work on. And so make sure that you use your little spiel to introduce yourself to your particular patient, with, of course, always remembering your title, student physical therapist. The next thing that you want to look at in an outpatient setting is you want to look at the patient's posture. Are they sitting down and filling out their paperwork? Are they hunched over, or are they sitting with proper posture? When they're walking in front of you, you tell the patient, you greet the patient. Now you're saying, let's go into the eval room. Go ahead. I'll walk right behind you, and you're automatically doing a functional activity assessment on them. That is, you're seeing how they're walking. You're seeing what are the places where they're deviating and where they work. Seeing them already walk in front of you, looking at their posture, you're looking at their alignment, you're looking at the places that they need to improve on. And this is all without the patient even knowing that you're actually already observing them. Go ahead and get started on that when you initially greet the patient and have them walking into the room. When you're sitting there in the room with the patient, you want to ask about their chief complaint. And majority of the time, it's a really good idea to document the chief complaint in the patient's own words. That way it's very clear that those goals or the complaint that the patient has is actually, it's not being misinterpreted from what they said to what you've written down. So it's a good idea to put it in quotes as to what their complaints are, and then you can actually do the same for their goals as well. Asking the patient what their goals are towards the end of your eval, and then again putting those in quotes, and that way again it's not going to be lost in translation as to what their goals and their complaints are. To ask for the chief complaint, you can actually say, so what brings you into physical therapy today? Or you can say, out of everything that we've discussed, what is the thing that is mainly the biggest problem for you right now. And that's a great way of honing in on a specific problem that the patient has, even though they have a laundry list of issues that they want to work through. The next thing you're probably going to do is you're going to palpate the area or touch the area. So if they're coming in for their elbow and you want to see, is it hurting, is it tender to touch, or is there a swelling in the elbow? What is exactly going on? So what's important for that is for you to be able to then expose the area. You want to expose the elbow. You're not going to look through it with over a chunky sweater. You're actually going to look at their actual skin and figure out what is the color of the skin. Is there swelling? Then you would probably take a girth measurement. So always expose the area, figure out what's going on underneath whatever clothing that they're wearing. The next step is usually looking at their range of motion, so their physiological range of motion. Now, depending on the problem that they're presenting with, that could mean active range of motion, in which the patient is going to move their own limb through space, or it can be passive range of motion, in which you're the one, as the PT, moving their body in space. And so you want to ask them, what are they coming in for? For example, if they're coming in for back pain, you're probably going to have them do lumbar flexion, which is folding forward to touch your toes, for example. And then if you are, if they're coming in for some shoulder pain, then you might want to do shoulder flexion or extension, whatever those ranges of motion that you want the patient to go through. That could be active, which is the patient doing themselves, or passive, which is you doing it. But you also want to make sure that you know what the normal ranges are. So, for example, for shoulder flexion, the normal range is 180 degrees. And then you want to be able to document, okay, well, did the patient meet the 180 degrees? Is it within normal limits? Or did the patient not meet it? They were minus 10 degrees, or whatever the case might be. You want to check out their range of motion when they are coming in for their initial eval. The next step is special tests. So depending on the nature of the problem that the patient is coming in for, you have a lot of these tools that when you're going in for that first clinical. So special tests can be figuring out, for example, if we're going to use the ankle, figuring out which ligament might be torn. If the patient came in and said, I'm just having so much instability in my ankle, then you might want to use some of the special tests that you've learned to figure out, well, what's the reason? What is causing it? Is it a muscle? Is it a ligament? What is the problem? And what structure is specifically causing it? So in order to implement those specific structures, you have certain tools that you will learn that can be then used in your clinic. So depending on the time that you have at this point and during the eval, you can either go ahead with the special test or pretty much pick it up the next time you see the patient. So let's say you weren't able to get the special test done. It's okay. You've told that the patient should come in, twice a week for therapy. The next time that they come in, you can do the special test then and see how they're doing. Special tests are really important to rule in or rule out specific structures. So certain tests for the hip joint, the knee joint, the elbow, whatever it might be, you're trying to figure out what specific structure is responsible for the pain that it's causing the patient. Now, you can use tests depending on their specificity and sensitivity levels to rule things in, to rule things out. So it's also important to know the statistics behind the test that you're going to be running to ensure that you're, not ruling something out when it should be ruled in. So knowing those specificity and sensitivity numbers can be a good idea. Again, this is not something that, this is not something you're going to need to memorize, essentially, because you're going to take your notes with you into your clinic, hopefully, and then you're able to look at your notes if you really need to really quickly. Again, not recommended that you do this in front of a patient, but once you seeing the patient, you're going to say, I'm going to step out for a really quick second. I'm going to bring these tools. And then while you're bringing, the next TheraBand around, you're going to go ahead and look at those numbers really quick and make sure that you're understanding what you're doing with the patient. This is the next step that potentially was the very first step that was done in the clinic. At least in my clinic, that's how it was usually done. And I think majority of the clinics probably do it this way, which is when the patient comes in, the receptionist at the front desk is then going to ask them to fill out a specific questionnaire, and this is the standardized outcome measure. So majority of the time, let's say someone's coming in with low back pain, the questionnaire that you might give them is the modified Oswestry scale. So that's specifically for low back pain. It's going to ask the patient several questions about, what triggers the pain, like what brings the pain on, how is it, how does the pain subside, what activities are you able to do comfortably, or what activities are you not able to do comfortably with this pain. And so the standardized outcome measure is a tool that you're going to use from the initial appointment. Okay, this is how the patient is doing the first day that they have come to see you, and then you also have them fill that out depending on how long the visits have been in the middle, which would be considered like a progress note. And so you would want them to fill out the outcome measure once again to see how they've improved. Hopefully they've improved, and then towards the end of your visits, the same thing. You're going to have them fill out this questionnaire to see how have they improved, and that's going to be really, really important because you want to make sure that you're able to track improvements in your patient's progress. You're trying to figure out what the function and the pain of the patient is initially, and then how has it improved as they've continued physical therapy. We kind of touched on this a little bit before, but the very last thing that you should do while you're still documenting in your eval is asking them about their goals. The goals are really, really important for us as physical therapists because we're not just treating their pain, we're usually trying to get them physically well enough to participate in the things that they want to do. For example, when I was working in outpatient physical therapy, I was working in a town that had a beach nearby, and so everyone majority of the time was like, oh, I want to go on the walks on the beach again, but my ankle hurts, or my leg hurts and I can't do that. Or people would be saying that they want to surf again, but their knees, giving them a lot of trouble, or I've just had something happen to my hip and I'm not sure. So the idea being that us as physical therapists, not only are we just treating, the pain or the impairment that they're coming in with, we also want to help the person become physically well enough to then be able to return to the things that they do in everyday life, which I think is so, so important. Because, imagine if there was something that, you aren't able to do anymore that you really, really enjoy, it's going to make you kind of, not really enjoy life as much. And so as physical therapists, we get to help people get back into their life and get back into doing what they like to do best. And so in order to figure out what people want to do, you have to ask them their goals. And again, you really want to make sure, if you're able to quote them on their goals. Hopefully they're able to meet these goals by discharge day. If you liked this video and you like physical therapy related content, please like and subscribe. If you have any suggestions for other videos, leave a comment down below. Otherwise, thank you so much for watching and have a good day.
What's up, everyone? My name is Pauline, and I'm a physical therapist, and you are watching Clinical Sprinkles. For those of you who are new around here, I work at an outpatient orthopedic physical therapy clinic, and I've been working at this setting for about 4 years now, and within those 4 years, I've worked at 2 jobs. So this video is to help you figure out what kind of things to look for in an outpatient ortho job, and what kind of questions to ask during the interview to make sure that you get a good sense of whether this place is the right fit for you. Make sure you watch this video all the way through because I am not going to be listing them in any particular order, and so I don't want you to miss out on any good information. The first point we're going to go over is your schedule. One of the perks of being an outpatient ortho is that it's not typically open on the weekends. However, some clinics are open on Saturdays. So that was one of the big points for me, was that I didn't want a job on Saturday or Sunday. So make sure you're checking that clinic hours and seeing if Saturdays may potentially be a responsibility for you. Sometimes those are on a rotation basis. That's assigned to the PT. So if your schedule on days of the week is going to be a problem, make sure you know that going in. Also, it's not unusual for a new grad PT to get the later shift. I definitely did. My hours were almost from 11 to 7:30 p.m. at night. If you have any obligations on like what time of day that works best for you, keep that in mind as well. Being a new grad, I was very flexible, didn't have a family at home that I needed to come home and take care of, so it worked out well for me. So totally case by case, but make sure you feel comfortable with the schedule that you're assigned. So one of the big questions for me was, how many patients am I expected to see in a day? This gives you a general sense of of how busy you're going to be in a typical work day. So if, for example, if you work 8 hours and you're expected to see 14 patients, that's actually, since they were on every half hour, I was really doing treatment for 7 hours and then kind of a buffer of an hour to do your documentation, I guess. At the place that I'm at now, it's been kind of slow still because of COVID, so I haven't had actually a full schedule. So far I've been seeing patients on the hour, sometimes on the half hour. The red flag that you want to look for is that you're not seeing 20 plus patients, that they're able to kind of multitask, see 4 patients in 1 hour, get one person started on heat, another on a modality, the one on exercises, and one on manual. So then all 4 patients come at the top of the hour, and then they get juggled around like that. Me personally, I'm big on one-on-one patient care, and so that doesn't vibe well with me. So if you're seeing numbers in the 20s and being in like a shorter amount of time span, be mindful of that. So the question you would ask is, how many patients would I see in a typical day? So then of those patients, you also want to be mindful of how many evaluations you're going to see in a day. So for example, my first job, we didn't actually have a hard rule of, a max cap of how many evaluations you would see, but typically the most I would see is 4. The worst day I've ever had, or the most evaluations I've had in a day, was 5. But again, it wasn't like a hard max cap. But evaluations take a lot more time, a lot more brain power, and a lot more documentation. So you want to be mindful that if you're going to have 14 patients a day, that they're not all going to be evaluations, especially if you have a PT assistant functioning at the clinic holding your own schedule, because maybe they're seeing all the follow-ups, you're doing all the progress notes, discharges, and evaluations. I think generally just figuring out how many evaluations you see in a day is a good place to start. So working in outpatient ortho, you have the opportunity to see a very large variety of patients. So the next question would be, what patient population will I see here? Will you be seeing geriatrics or for high fall risk or balance issues? Are you going to be seeing any sort of neuro patients, any post-op? You'll most likely see like the chronic pain, had this pain for over 5 years. That's going to be at most outpatient ortho clinics. Athletes, are going to see student athletes in high school. They're going to be higher functioning, that are going to challenge you to give more higher level, more fun prescriptive exercises. Women's health, vestibular, TMJ, there's a whole variety of outpatient ortho conditions that you may see. And so kind of getting a gauge of what they see the most often, or like what they see in general as well, may be helpful for you to gauge if this is the right fit for you, because I like to have a huge variety in what I'm working in, keeps me on my toes. I'm well versed in many areas, and so that's just my preference. But depending on what you're looking for, you want to make sure that they have your special interest at the clinic that you're going to be applying for. Now working for about 4 years, I want to make sure that I get to practice the way that I want to practice. So I call this the autonomy to practice the way that I want to. Am I going to be micromanaged by the supervisor or clinic director to treat the patient the way that they want the patient to be treated? Or do I get the freedom and decision to figure out and prescribe what I want to give? Are the prescriptive exercises going to be cookie cutter and they're on this like flow sheet and you're only allowed to give like these exercises and these progressions? Or will I be able to give what I want to find it in my channel? And the clinic that I'm at now does use a lot of ultrasound, and that's something that I really didn't practice before. But am I still able to give patients treatment without incorporation use of ultrasound? That's kind of the part where it's the autonomy of practice. Am I able to figure out and prescribe what I see what's best for the patient? Or am I supposed to follow a system and model that has already been put in place for however long? The next one is a big one for me. If you know me, I am all about learning, growing, how to get better. That's why I have created this YouTube channel, is to help you all become better, giving you clinical sprinkles, clinical knowledge about how to become a better PT. And so this next one is huge for me. It is mentorship. Especially being a new grad PT, every single interview I went to asked about mentorship. What kind of mentorship do you provide? Is it direct one-on-one? Or is someone going to be shadowing me? How many in-services are you going to have each month? What kind of in-services do you have? What kind of resources do you give to new grad grad PTs to grow, develop, what kind of course or track work that you provide to them, what kind of resources, who can I talk to. Mentorship is a huge thing for me, and that was huge, especially being a new grad. So make sure that if you're new or you still want that continued guidance, that you're asking about mentorship, and then being specific on what that looks like, so that once you get hired on, then you can kind of start to create a schedule based on the conversation that you have. Another piece to keep in mind is, who do you work with? The support staff that you may have may include a PT aide, a PT assistant, and or other PTs. Being a new grad PT, I would be very cautious to be hired in a clinic where you're the only PT there. I had a lot of questions coming out of school, and so being able to ask my PT that was sitting right next to me, who shared a desk with me, questions was incredibly valuable. Although I may have been annoying because I asked a lot of questions, having a resource right there to me, or him being able to direct me to hey, there's answers in this book. Why don't you read this book? Also, the benefit of working with another.
We provide pretty much all rehabilitative services, physical therapy, occupational therapy, and speech therapy. So specialized services that we offer is pelvic floor therapy, dry needling. We have a certified therapeutic pain specialist, a certified hand therapist, and a certified Parkinson's wellness recovery therapist. We have a 20 by 30 pool to provide aquatic therapy. We also have a wide range of equipment, stationary bikes to treadmills to new steps. We also have access to some higher level equipment in the fitness center if we need it. But our therapists do a lot of manual therapy as well. So some of that doesn't include equipment, but it's teaching the patient how to function with the disability they may have. For aquatic therapy, usually it's patients that maybe aren't able to tolerate therapy in the clinic, or they have a weight-bearing status restriction that they would benefit from being in an unweighted environment in the post setting. All our physical therapists, occupational therapists, and speech therapists are licensed by the state of Texas, and most of them have doctorate degrees. Some of the clinics you might go to, you might see a technician for part of their treatment, but here we have one-on-one treatment with a licensed therapist the whole duration that you're here. We strive to provide the best rehabilitative therapy so that the patient can reach their max potential and regain their quality of life that they had prior to their illness or injury. I have been a physical therapist for about 26 years. And of course, I got into this career to help people. That helps me continue to build this department so that it provides the best therapy that we can offer in this community.
So the question is, inpatient or outpatient physical therapy? Before we start, I have to recognize my own biases. Just everything I'm going to talk about is based off of my own past experiences. So there may be a lot of subjectivity here. But regardless, I hope that this discussion is going to be beneficial to those who are choosing between inpatient and outpatient.
Okay, so today we're going to go over some basic ICU skills. If you've never spent time in a hospital, these are good things to practice and learn about before you jump into patient care. So first we're going to go over how to properly keep a patient modest. So putting their gowns on, believe it or not, can be a tricky thing. And then we usually put a second gown over a patient's back to help keep them covered, since our gowns do open in the back. So we have our patient Liza here today that I'm going to demonstrate on. Hi, Liza. How are you? I'm well. How are you? Good. I'm going to help you get your... So each gown has several buttons on each sleeve. The gown is tied behind the patient. One big marker to look out for is the neckline on the patient. So we want to make sure that that's in the center, and then we should be able to button up each of these. And it's really nice if the patient has lines. To take a gown off, all we need to do is unbutton that, and we can pull this right out from underneath and button it back up on top as needed. We're just going to button part of this sleeve here. There also should be different size gowns depending on what hospital you're in. So obviously this is a standard patient gown. If you have a bariatric size patient, you should get them a bariatric size gown so it covers more of them. Okay, so next we're going to help Liza up to the edge of the bed. And after we do that, we'll make sure her backside is covered before we proceed any I'm going to use the bed to my advantage. These hospital beds, there's different models in each hospital, but they all have some basic functions of up and down, raising the head up and down, etc. So if you look on the side panels here, we have some labels: bed up and down, head up and down, knees up and down, etc. that we can use to help make sure that our bodies are staying safe and we have good mechanics with transfers. So I am going to lower this bed closer to the ground for when we get up. And lower the knees down so she's not going over a hill. And to lower the railing, there should be some sort of mechanism here to unlock the railing and slide it down. Some railings go sort of in a round motion to go down, some of them go straight down. So make sure to spend some time checking out the beds in whatever hospital setting you end up in. Okay, I am also going to sit Liza's head up a little bit here, just to make it easier for her to stand up. Sit up on the edge of the bed. Okay, Liza, I'm going to have you start scooting your legs this way towards the edge of the bed. Excellent. I'm going to help you with your trunk a little bit. Up to sitting. Excellent. Can you keep scooting forward to get your feet down to the ground? Good. We want to make sure her feet are planted on the ground. And we don't want to immediately walk away from our patient in case she doesn't have good trunk control. So I'm keeping a hand on her and getting a good feel for that. Okay. You okay sitting there for a moment?
I'm feeling good.
Okay. So next I'm going to show you how to prepare another gown to put over her back. There are two different ways that we like to do this. The first one is called making a cape. Both of them really make a cape, but again, our main landmark on these gowns is the neckline. So if you find the neckline, the rest of the buttons and sleeves are going to look like big floppy pieces. So our other landmark is going to be the tie on the neckline. That's what goes behind the back. So if we find the button that's closest to that tie and the button that's closest to the neckline, connect those two. Then do the same thing on the other side. So the button that's closest to the tie, button that's closest to the neckline. Now we have more of a solid piece of fabric here with two ties on it, just like a cape. So we're gonna throw this over Liza's back and we can tie it in front just like so. That'll help keep her covered. An alternative way to do this would be to come under the patient's arm. So using those same two snaps that we use, the one near the neckline and the one near the tie. An alternative way to do this, like big floppy pieces. So our other landmark is going to be the tie on the neckline. That's what goes behind the back. So if we find the buttons to the neckline, connect those. So the button that's closest to the tie, button that's closest to the neckline. Now we have more of a solid piece of fabric here with two ties on it, just like a cape. So we're gonna throw this over Liza's back and we can tie it in front just like so. That'll help keep her covered. An alternative way to do this would be to come under the patient's arm. So using those same two snaps that we use, the one near the neckline and the one near the tie, we come under her arm, snap there, snap there. Now we don't even necessarily need to tie that. That is on her arm, so when she stands up, that'll stay and cover her back. Okay. Okay, so our next step is we're going to get Liza the rest of the way prepared to get out of bed. Now that we've gotten her up, these modest gown. So one thing not to forget is our hospital socks. We don't want patients up with just regular socks on or with bare feet. A lot of patients don't like these, but I tell them it's hospital policy. We don't want them to have a fall. That's a lot of paperwork for us. So I'm just going to throw these socks right on. We can throw them over her regular socks. perfect. These have some nice non-skid stuff on the bottom. Something on these slippery floors. Next, we're going to throw a gait belt on. So I'm going to grab my gait belt, come around my patient, and come underneath your arms here, Eliza. Grab this through. Get it pretty snug here. Back through, and then we can just kind of tuck the tail in wherever we need. There are a couple considerations with this in the ICU. We need to be conscious lines the patient has. So if she had chest tubes or a drive line for an LVAD, any sort of drain here in this area, we'd want to be very conscious of where this is, not hitting those. We can also move it up into more of the armpit area, especially on men. That works pretty well to get a good hold of them, or to have it way down on their hips, as long as you have it nice and tight so it's not riding up. Next, I'm just going to show you how to switch the oxygen over. So Liza was on, let's say, she was on 3 liters per minute of oxygen on the wall. So if we look here, this is our oxygen flow meter, and there's just a dial here that dials up and down the oxygen. Remember that oxygen is a controlled drug, essentially. It has to be prescribed by a doctor. But we, as therapists, should have an order in our chart to titrate oxygen to keep levels above 90% usually. So we can titrate this. Often patients will need a little bit more oxygen when they're up and moving than they do when they're in bed. So that's something to keep in mind. So I'm going to take the oxygen off the wall and put it on our portable tank here so that we can go walking. So first things first, I want to make sure the portable tank has enough oxygen in it. So there's a little gas meter here, empty to full. We want to make sure that there's at least 1,000 in there. And then we're going to turn this on by flipping this dial. So we're going to put that on 3. We can hear the air coming out, so we know that it's on. Then we can grab this nasal cannula here right off the wall and put that end right there. Liza, I'm going to have you remove your mask so that I can put this nasal cannula on you for a moment. When we have the prongs on this nasal cannula, we want to make sure that they're facing up and out. That'll be more comfortable to go on the nose. So we're just going to place this in her nostrils and around her ears, and this part here so that it stays on. In these COVID times, we can have a patient place their mask back on. I'll turn this off for you, Liza, so you don't have oxygen in your nose. We can have them put their mask back on over the oxygen once that is on. We do have a few other options for oxygen delivery. I'll show you just some of our common ones here. So this is just a simple mask. If the people were on 6 or 8 liters, this would be the appropriate mode of delivery for that. Just goes on and over the head. And if they're on more than 10 liters, we typically want a non-rebreather, partial non-rebreather. This mask that has a bag, so it fills up a reservoir here of oxygen. Again, that just goes on over their face like that. They all have a very similar end to just go right on the IV pole or on the oxygen tank right there. Then, lastly, to make this portable, the IV pole, if you had IV pumps on here, it needs power, so it's probably plugged into the wall. This is something that's okay for us to unplug. We don't need to ask nursing about this. This is just general power. Everything on the IV pole should have battery backup on it. So depending on the configuration of your IV pole, you can kind of just move this around. Make sure those don't dangle. And now we're completely portable and ready to go. One other thing that you'll find in all your ICUs is your telemetry monitor. So different ICUs are going to have different brands. We use the Philips monitors here. Up here, if they were actually connected to our patient, we'd have all of our EKG, our SpO2, our blood pressures, respiratory rate. Depending on what lines they have, you might also have a CVP or a PAP, so that's just right heart function. So important buttons on here. There should, on any monitor, be some sort of silence button. So if there's something alarming as long as it's not something alarming that we need to alert nursing about. Sometimes if the patient's moving a lot, you might have a lot of noise on your EKG lines. It might beep, and we can just press silence to pause that alarm. Another good button that's usually on most monitors is the start-stop button. That is to take a manual blood pressure. If they have a blood pressure cuff on and a cord connected for that, we can press start-stop, and that will run the cuff to get a pressure there. In order to go walking with a patient or leave the bedside, most hospital monitors have some sort of portable telemetry. So these may look different, connect differently at each hospital, but we can pull this whole thing off, and we now have our EKG and our monitor all here. So before we go walking, we disconnect that from the wall. We can bring this over, and we can set it right on our IV pole, or we can hang it up here if you're tall enough to see. Just somewhere where we can see it, because in ICU it's important to be able to have an eye on your patient's vitals while you're up and moving. So now when we get up, we have that with us on the IV pole at all times. After our session, we're going to make sure that this patient is settled back in bed. I'm going to take her gate belt off because that's not comfortable in bed. We already took her second gown or her cape off, so she's not running on wrinkles. Go back right through. So we're going to put the oxygen still on her. We're going to take the oxygen and put it back on the wall. This is a really important thing to not ever forget when you leave the room, because if you leave it on the tank, well, the tank will eventually run out of oxygen, and then your patient will probably start to desat. So we're going to take this back off, make sure that is off, plug this back into the wall, and turn it up to the appropriate 3 liters that she was on. And we have this on her, of course. Next, we want to make sure that the IV pole is plugged back into the wall. That will, too, eventually run out of battery. Anything important in a hospital should be in red plugs. These are usually plugs that are hooked up to generators. So if the power goes out, these will kick back on. So anything important, like medications, ventilators, dialysis machines, should all be on there. I'm going to show quickly our patient lines in here. Doesn't need these, but if your patient did have restraints on before, we want to make sure to put these back on afterwards. So there's different kinds of restraints at each hospital. They typically have some sort of Velcro, some sort of buckle fashion here. And then depending on your facility, depending on the beds, we're going to have some sort of bar underneath here. And you can see there's even a logo here.